Hi, I'm David White. I know exactly how I got here into the sleep field. I was doing a pulmonary research fellowship, and I was interested in the control of breathing, the mechanisms by which we keep blood gases very precisely controlled in the blood. And I was measuring what's called the hypoxic response, taking somebody's oxygen down and looking at how they respond to it. And I'd studied this one guy. There was a wall between me and the person. They're watching TV as I make them hypoxic. And I had measured this guy a few times, and he had a nice brisk response. And I measured him a third time, and there was absolutely no response whatsoever to the low oxygen I was administering to him. And I thought, what is going on here? I ran in, and he was sound asleep. And I thought, wow, sleep must have something to do with these responses. And I was working with Neil Douglas at the time. And so we got very into the idea of what does sleep do to ventilatory control? And we found that it did quite a bit to ventilatory control. It sort of got me interested in sleep itself, sleep apnea pathogenesis, and one thing and another. It sort of took off from there. And, I stayed a pulmonologist for a long time, but sleep eventually overwhelmed the pulmonary, and I've got completely focused on sleep in the last 20 years of my career. So that's how I started. So it's totally from the research side. The programs I was involved with, I guess I'm trying to think, my first real job was in Hershey, Pennsylvania, and we set up, and Anthony Kales happened to be there, and he had a large lab, but he wasn't very focused on the same things we were focused. So Clifford Zwillick and myself set up a research lab, and then eventually became a clinical lab. There was no formal training in sleep at the time, but the people did that. So we certainly did that. I went back to Denver in 1988 and set up a lab in the Denver VA hospital, which did not have a sleep lab. And we set up both a research and a clinical sleep lab, and became very, very busy with the 8-state area around Denver from the VA point of view in terms of all the studies. Got to where we were backed up 8 or 9 months in terms of the sleep studies we were doing. Also took over the National Jewish Sleep Laboratory and sort of expanded it out while I was in Denver. I moved to Boston in 1996, and they had a sort of a sleep program going at Brigham and Women's Hospital, and we expanded that and got the clinical lab more active, and started a big research program at that time, which everyone will recall. We then outsourced that program to what became known as sleep health centers, which was successful for a substantial period of time, but ultimately sort of fell to the craze for home sleep testing. It was not set up economically where that would work very well, and that eventually went under. But I guess, from my point of view, I was very involved in the clinical stuff, but in all these sites, we had developed substantial research programs trying to understand the pathophysiology of sleep apnea, which we figured a lot out about it over the 30 years of the career in terms of what does cause sleep apnea and how people are different and whatnot. That was actually very quick. I was involved with the ATS, and this is the early 90s, involved with the ATS. And the ATS was, not the ATS, but a number of us were sort of forming this organization called the American Sleep Apnea Association. This was Paul Surratt and a few others and myself. And we were sort of evolving in the sleep field, but it was all from the sleep and breathing and sort of the ATS side. And we got asked to participate in a few things in the broader sleep field, because I had no exposure at that time to the it was called American Sleep Disorders Association at that time, or the SRS or any of that. But I got invited to give some talks and start participating, and very quickly, like in 1992 or 3, they said, "Would you be on the program committee?" So I said, "Okay." So I was on the program committee for about a year. And then they said, "Would you be on the board of directors for the American Sleep Disorders Association?" And I said yes, and I got on that. And I eventually rose to the presidency of it, but it was a very funny story as to how I ended up getting president. Then, as now, the executive committee for the AASM basically picks out who's going to be the next president. And they, so as the year I was about to migrate off, they came in and they said, "We have selected for president next year will be Wolfgang Schmidt-Nawara," which was fine. I said that, we were all cheered. And so Wolf stands up and he goes, "I'm very pleased and happy that you selected me, but I think there's a better choice here, and that should be David White." And this caused a big ruckus. Everybody didn't quite know how to behave in response to it, particularly Carolyn Hiller, who was the head of the organization at that particular time. So they asked Wolf and I to step out of the room, which we did, and we literally sat there for an hour or two while a lot of discussion went on. And when we went back in the room, they said, "David, you're the president. You're going to be the president-elect." And with that, Carolyn Hiller quickly resigned, and which ultimately obviously led to the incoming of Jerry Barrett. But it was a very fast process between my first exposure to him, you're on the program committee, you're on the board, and then sort of on the presidency. There were a lot of things going on. I mean, the field was pretty immature. I mean, there weren't hardly, the clinical field was small. There weren't a lot of sleep labs in one thing and another. But there were some real challenges that the American Sleep Disorders Association had at that time. Things like the fact that they didn't control the meeting in any serious sort of way. The abstracts from the meeting were published in Sleep Research, which was controlled by Michael Chase completely. So we had basically no control of the abstracts. The journal Sleep was sort of being run by Christian Guilleminault for the last 20 years. He'd sort of been the editor. And the relationship with the SRS was fairly contentious at that time. I mean, the two organizations were sort of going their way. They weren't working very well together at all. The meeting was a little bit more chaotic. I remember those early program committee meetings. We'd gather somewhere and just throw the abstracts on the table and start picking them out and trying to put together sessions. It was a bit chaotic at that time. The SRS was a mess because all the money from the SRS was going to Michael Chase for various organizations. He had this Arrowhead meeting. He had, Sleep Research, which was the abstracts, which were not referenceable and whatnot. And so there was a lot of internal conflicts. And very quickly we dealt with the abstract issue. We said, that's no more. They're going to start being into sleep. This is when I became the president. So we basically fixed that one. We sort of started getting the structure together for how we're going to run the meeting jointly with the SRS. And I spent a fair amount of my year as president actually trying to merge the SRS and the American Sleep Disorders Association at that particular time, because sort of in my mind, I mean, you didn't need to have both organizations. I mean, it took a lot of extra energy to run the two of them, and I thought that we could have run things better with just one society. I still think that. I've never felt like that. There was much benefit in having two, and we got reasonably close. But in the end of the day, I was in my negotiations with the SRS. I was, sort of like Israel. I was probably making offers to them that I might not have been able to fulfill from the ASDA side. They might not have done it, but even with that, giving them SRS, a lot more control than their numbers justified, they ultimately at the end of the day wouldn't do it. And this was Chris Gillen and I was sort of trying to make this whole thing work out. So we stayed separate. But it was a very interesting time, a lot of politics going on in one thing and another. But the sleep, the clinical sleep field was just sort of starting to emerge at that time, and it was, getting going, but it was very much smaller than it ultimately became. Yes, I mean, as I told you, when I became president, Carolyn Hiller decided pretty promptly that she was leaving. And so we put, the board became the selection committee, okay? We didn't break it out. We did some advertising in one thing and another. And I remember we gathered, I think it's in Arizona somewhere this is about probably the spring of 1996. And we were going to just, what we did, we brought a number of people in to interview that had gone through the first vetting process and whatnot. So we flew them into this meeting. They were going to meet with the board. And of the people that came through, Jerry Barrett was just clearly the best. I mean, there was just no question in terms of his experience and his stature and one thing and another. But it was a very funny sort of process because we were, once we sort of wanted him, we then sort of brought him back in to sort of discuss, what's his salary going to be, blah, 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 blah. And Milt Ehrman felt like he was a great negotiator, so he wanted to lead the discussion. And as you might imagine, Jerry sort of overwhelmed him immediately and sort of took control of the conversation. But I'll never forget one thing that was sort of said, and we were talking about what Jerry's salary would be. And, Milt was saying, that's probably way too high. And Jerry just looked at him and says, Milt, I'm going to have to raise the money to pay me. So don't you worry about it. We'll take control. But Jerry came in at the same time I became president. And so we sort of both, sort of started up together. And it was a very positive year from that point of view. Jerry and I got on extremely well. We were traveling all over the place, dealing with all kinds of issues and one thing and another. But it was a productive year, and Jerry put the organization in a totally new footing. I mean, he had much more business sense and understanding professional organizations and things like that than Carolyn Hiller did, and he was responsible for a lot of the successes in those days in terms of pushing things along. So, but it was a very, sort of interesting and lively time. I mean, I thought, for one, some of the mechanical things I said, we got the abstracts away from Michael Chase. We got the meeting organization better in terms of how that was going to run. We got a new executive director in there. Research, I was driving hard for research to become part of the agenda of the American Academy of Sleep Medicine, as opposed to, clinical practice of medicine is the pure or the driving interest of the organization. So I think, and we made the relationship with the SRS better, despite the fact that we never could merge together. I think we sort of forced Chase to the sideline in many ways, which he contributed a lot scientifically, but I think politically he was quite problematic. So, a lot of things got going. The field was evolving. More people were getting interested. We started in the early days of sort of, the National Sleep Foundation was formed in those years, not when I was necessarily president, but as the years leading into it, and that sort of got going. The relationship probably with the American Board of Sleep Medicine, was getting better, and that whole thing was evolving along. It wasn't at that time that we started approaching the various American Board of Internal Medicine or the American Board of Medical Specialties organization didn't, but that sort of followed on eventually. So there was a lot of things in terms of the progression of the field that were sort of really happening at that particular time. So it was pretty exciting. Yes, that was before me. So we were ASDA at that time, and they had just spun out the National Sleep Foundation, and it was quickly obvious that we couldn't control what the National Sleep Foundation was going to do. I think somehow we thought they would just be an offshoot of us, and we did. We spun them out. We gave them $100,000 and said, "Go to it," But we thought we would still be a major influence, and very quickly we realized that was not true, and they were going off all kinds of directions that we didn't agree with. I'm not saying that they weren't right, but they just weren't the same ones we'd sort of imagined. So it was, it was interesting. I think the people that at that time, the people on the board and in leadership were people like Paul Fredrickson was there, Jim Walsh was there, and he was very much involved. Mayor, I believe, was around at that particular time, Mayor Krieger. But it was a changing sort of world. People like that were starting to come in were newer and somewhat different people like Stuart Kwan, like Dan Bizey. Wolfgang came in, Smith Noir, during that particular time. So there was a whole new echelon sort of people that were there. David Dinges was actually on the board of the American Academy of Sleep Medicine at that time. Some of these people had some pretty good insights into where things needed to go, and I thought they were a sort of a younger and a more dynamic crew. it hadn't been that long when I got there since, people like Bill DeMint had been president sort of forever. And had spun off to where it was a more, democratic organization than maybe an autocratic one. But there were a lot of good people in those early days, and it was an exciting time. My lab was always interested in basically what causes sleep apnea, both central and obstructive. And we went through all kinds of phases where, as I said before, initially we were primarily interested in sleep and ventilatory control. But I can remember it was about 1982 when a paper came out. I can't think of who the first author was, but I remember he presented at the ATS meeting that he said that patients with sleep apnea have smaller upper airways. And it was sort of, wow, that's interesting. Haponic was his name, I remember it. And so I sort of moved from ventilatory control to upper airway anatomy and upper airway control. So we did a fair amount of imaging stuff around the upper airway, but we really got into what controls the muscles. And I can just remember years of sticking needles into genioglossus and tensor palatinis and all the palatal muscles and staying up all night, night after night, recording these signals and trying to understand what sleep did to them. And then we got into sort of sleep control stability. What wakes people up, and we came up with the idea that it's basically what wakes them up is increasing respiratory drive. But to make sort of a long story shorter, it ultimately culminated when I was writing a review paper that was in the Blue Journal about the pathogenesis of obstructive and central sleep apnea. It's sort of the whole idea of phenotyping, or what we now call endotyping, sort of came into existence. And we wrote the paper that basically said, look at these 4 traits, which are basically anatomy, muscle responsiveness, ventilatory control, and state stability and loop gain. Sorry, maybe I missaid that. Basically, anatomy, upper airway muscle response, state stability, and loop gain were the primary traits that people would have that would dictate, did you or did you not have sleep apnea? And that has taken off substantially now. And there's a lot of, research going on around that. And that hadn't changed much. Those 4 have sort of stayed the course probably over the last 10 or 15 years. And it's driven ideas about who should be treated and how you can treat them. And can you go after these traits individually? Which hadn't worked out perfectly, but it has worked out to some extent. We sort of learned a lot. Andrew Wellman and Atul Malhotra came into the lab when I was in Boston and added a lot of value around it. Andrew particularly figured out how to measure these traits in ways that we never had. I just knew they existed, and I could stick needles in muscles, but that was not very practical and whatnot. And he learned how to measure them, figured it out, and then some of these Scotty Sands and that group came in and figured out how you can measure them off standard PSGs and whatnot. And so it's gotten where I think right now, it's certainly in a research setting, you can measure these things pretty straightforward. And my hope is that the technology to do that will be taken up by the data acquisition system owners, because basically it's just programming. You look at the standard signals that are measured on a PSG and you can endotype people. And the hope would be that would get spun out to where it's actually done and these numbers are given to people, and then they can actually use that information to make decisions about care of the patients. Also, the thing that sort of got going in the lab at that time was this idea of the other ways to, measure sleep apnea severity. And I'll never forget, we had a retreat with Andrew's lab up in Breckenridge, at our home in Breckenridge. And we sat down and we were looking at all the other bars, and we said, you're going to start working on figuring out better ways to sort of get at what are the important things happening during sleep apnea that are going to dictate cardiovascular outcomes and one thing and another. So he jumped on that and came up with the hypoxic burden and came up with the heart rate change at the end of the events, which are panning out to be interesting possibilities for future activities. But during the 10 years I was full-time at the Brigham in Boston, we spun out a lot of good young people that have really thrived. Since then, Atul, Sanjay Patel, Najib Ayas, Andrew Wellman. I mean, a lot of these people that are running around right now, and some of them that are still there, like Scotty Sands and Ali and whatnot. And so it was an exciting time scientifically, and it was an exciting time from the point of view of trainees. And there are also people like Yura Pilar, who's now in chief of pediatrics at one of the hospitals in Israel. You know, he's a very prominent individual. So we had some great fellows in those days. The AASM has done a lot of things that I think are important. They have, let's just think about this. One, they were involved obviously in terms of getting the testing situation squared away, in terms of, you know, the American Board of Sleep Medicine went for a long period of time, was eventually spun out to the American Board of Medical Specialties, and the AASM was involved in that. So that has become much more solid than it ever was before. Sort of the idea of the managing the sleep laboratories in a meaningful sort of way, that you get them set up in their basic rules and regulations about how best to do this and whatnot. And so they have certainly been sort of prominent in that. They've gotten to where this meeting, you know, in cahoots with the SRS is it's a good meeting. It's not perfect, but it's gotten to be quite good. The journals have been improved, meaning sleep is improved. Eventually it was spun out, obviously, to the SRS, but they started the Journal of Clinical Sleep Medicine, which is really has progressed nicely as a meaningful journal for the field. They've gotten political in terms of dealing with Congress and whatnot, and driving behaviors in terms of that. It's interesting, I think things have changed a bit. When I was president, I would go to NIH every quarter and always meet with Claude L'Enfant, who was head of the National Heart, Lung, and Blood Institute, where the National Center was. And I'd go in and raise Cain and try to get RFAs out and try to, push the agenda, because we felt sleep was badly underfunded. And I'd go see the heads of some of the other institutes that had a particular focus on sleep. I don't think they do that kind of thing as much as was once done, but they do lobby Congress and whatnot. So I think that, that's sort of an important outcome. But I think the field has coalesced around it. I struggle a little bit that I think the AASM got a little too focused on sleep doctors making money as opposed to evolution of the field. Okay, and I think we took our eye a little bit off the ball, and we've had obvious problems as the fellowship programs came out, and especially after the American Board of Medical Specialty took over, the numbers were not as good as they should have been. They weren't filling all the programs and whatnot. The AASM had to go through this substantial economic problem when sort of home testing took over and the things came out, the cash cow of the sleep field. Sort of the PSG didn't fall into disfavor, but it just got to where you couldn't do a PSG on every sleep apnea patient that came down that obviously had sleep apnea. And that was a pretty disruptive thing for the field and whatnot. I think the American Academy of Sleep Medicine probably didn't handle that whole thing as well as they could, because I remember distinctly I was consulting for a company called Itamar that had come out with this watch pat. And we were trying to get a CPT code. We'd go to AMA CPT committee meeting. I'd go with them every time, and we'd make our case, and the AASM would send people there to do everything in their power to make sure we did not get a CPT code, because they didn't want any home testing to evolve. They really fought it sort of tooth and nail, and it was very unpleasant. And I finally remember, I distinctly remember that it was so obvious at the committee meetings that the focus of the AASM at that particular time was trying to make money for doctors, and that's why they wanted the PSGs to keep going. That I'll never forget when the AASM representative stood up and was arguing why this shouldn't get a CPT code. The chair of the committee looked at him and said, "You shut up. We've heard enough of you." And they I think overreacted, and they put CPT codes and WatchPad on everything that came through. And I think it was a reaction to the American Academy pushing so hard for the money. So I think that was sort of an error of the field or the Academy, that they were too interested in trying to make money for sleep physicians. But it was a painful time, because once the PSGs were massively reduced, a lot of people that were coming into the field that came into it because of the money quit coming into it, and so there were less fellows and one thing and another, because it was not as financially attractive as it potentially had once been. Now, a lot of that sort of, I think, has corrected, and I think things are settling out. But I think the AASM, things would have gone smoother if the AASM had recognized that every patient doesn't need a full PSG to diagnose sleep apnea. They'd worked with basically the societies and the insurance companies and things like that. I think there would have been a much smoother transition from one way of doing business to another, rather than the payers really dictating to the field exactly what they were going to do. So that was a complicated, conflictual sort of time. The AASM now, in sort of my opinion, is still probably more, it has, I don't like to use the word guild, but it has become sort of much more the practice organization as opposed to the scientific organization for the field. And the SRS is sort of the scientific focus for the field, but they're not perfect either. And it would, again, I think if these two organizations got together and were able to, work together or be a single organization, you might be able to do things better. But the AASM, I don't want to be overly critical. I think they have done a lot of things that have helped the field immensely and matured the field, and it's, very complicated what to happen. But there were a few missteps that I think could have been handled better. Jerry Barrett's has been one of probably the most interesting characters in the field over the years. He's sort of in the Archie Bunker of the sleep field. He's very dogmatic with all his ideas, and some of his ideas are interesting. But he's been he and I got to be very good friends and have been over the years and whatnot. And he contributed immensely to sort of the evolution. So I think he's been certainly one of the major characters, that over the years in the field. But they've been some great leadership people that have contributed a lot. Yourself, Larry Epstein, you've done, a lot of for the field. But there've been lots of people, and it's evolved along. The AASM board has gotten to where it's interesting. It used to be largely academic, and now it's not as academic as it used to be. I think there are a lot of people that are basically practicing physicians and whatnot, and a lot of people have gotten to be president that are practicing physicians, which in some societies wouldn't happen from the point of view that, like ATS would never have just a clinician be the president. That's nothing right or wrong about it. It's just a different sort of focus. But to me, if you had to say who's been the biggest character over the years in the AA, the American Academy of Sleep Medicine, it's certainly been Jerry and what he's done. Well, I usually would say that the AASM is the professional organization that represents the sleep field, the sleep physicians, sort of in all their primary activities. It is the organization that represents them. I'll never forget when I stepped down from academic medicine and moved to industry, and this was in 2006. I was editor-in-chief of the journal Sleep at the time, which I had to give up, obviously. And I remember I wrote an editorial that was called Not Farewell, sort of talking about my exodus from full-time academic medicine and whatnot. And the point I was trying to make was that we're not moving fast enough. The sleep field is not moving. At that time, the most obvious thing I jumped on, I said, we're still handling PSGs the same way we did in 1963. And I use the analogy of what's happened in radiology. Back then, if you wanted to see if somebody had a subdural hematoma, you did a skull series and looked at if the mastoids were lined up. And now you do MRIs and CTs, and they have progressed massively. And we're still using the same technology, and we hadn't progressed nearly as fast as we should. And I think that's still true. Like the sleep study methodologies we're using are 30-second epochs and all this sort of stuff are crude as can be and don't tell us near as much. And there are people working out there, for instance, people like Magdi Yunus, who's got his odds ratio product, and Emmanuel's Mignot's been trying to get quantitative EEG and things going. There's a lot of stuff going out there, and we need to progress it faster. Everything needs to be going faster because we're not moving as fast as and progressing up. That reminds me of another story. I remember in 1995, I was giving a talk at an advanced sleep course in Adelaide, Australia. And they asked me to talk about the future of sleep medicine was my topic. And I made the comment, I just said, look, again, 1995, and I said, if CPAP is still the way we're treating sleep apnea in 20 years, we're going to be a failed field. We've got to get better. We've got to make progress. And Colin Sullivan, obviously the inventor of CPAP, stood up and he said, David, you're dead wrong. He says, in 20 years, CPAP will be as comfortable as glasses. And when I tell that story, I say, it turns out we're both wrong. Because here we are 27 years later, and CPAP is still the main way we're treating sleep apnea. And we're not a failed field, but it certainly isn't as comfortable as glasses, and I don't think it ever will be. But I mean, again, I was trying to push the field to get going faster and come up with new things. And now I'm working on trying to evolve drugs to treat sleep apnea, which I think would be a very exciting outcome if we could come out with something that really works well. So I guess if my departing comment would be, we got to go faster, and the AASM needs to push that because the SRS is not focused on management of patients and whatnot. And we need to progress the science so we can deal with the patients much better than we're doing right now.